Thank you guys. It looks like we have a great crowd on the line here to talk about women in substance abuse treatment with our particular focus on African American women today. I want to give you just a word of warning. We're going to get into some heavy material today that I think will open all of us to the type of thinking that we need to have really to make a difference on retention and outcomes for Black women in substance abuse treatment. So, to jump right in, we know that there's considerable evidence that gender differences in substance use disorders do exist. And those differences exist as it relates to the early risk factors for developing a substance use disorder. So, those would be genetic risk factors, biological risk factors, psychological risk factors, social risk factors. We know that those differences exist between the way women and men respond to substance abuse treatment as we currently kind of have it structured in this country. And we know that recovery rates are different among women and men, and relapse factors are different between women and men. And I do want to take just 1 minute to say that I kind of developed this talk with a binary gender mindset, like men versus women. But we do have to recognize that gender is a spectrum. And so, even as we look at those who don't identify binary male or binary female, there are even more gender differences once we take a more inclusive approach. And so, I wanted to start kind of with what does it mean to be African American? So, the terms that we've used in this country kind of to describe people of color have varied over time, right? And so we know if we look historically, then there was Negro, and then there was Afro American, and then there was Black, and now the more contemporary term is African American. But what does it actually mean? The point that I want to drive home is that Black women or African American women is not a homogenous group, right? So when we look at women who appear to our eyes to be African American women, it's typically women who have some descent from the continent of Africa, but these can be American born women, these can be African born women, these can be Caribbean women, these can be Latin American women. Put so many more variables on the list for even just place of birth and kind of the resultant implications that that has for identity. And the first thing we have to recognize is that we cannot lull ourselves into thinking that because we see who appears to be a Black woman in front of us, we know anything about her. And so when we think about kind of the diversity that does exist in the community or the population of women, and I like to say who self-identify as African American, because that's the first trap that we fall into, is that we believe our eyes, right? So we take a look, you would take a look at me and you would say, oh, she's an African American woman, but you don't know if that's how I identify myself. And so one of the first things we want to make sure is that we are not putting an identity on the people that we're serving, but rather that we let them identify themselves to us. And so if we take a look at the population who self-identifies as African American women, there are major differences in cultural identification, major differences in income status, educational status, marital status, major differences in occupation and lifestyle between women who identify as African American in the United States. And what we want to be able to do is kind of take a nuanced view of being able to really be comfortable with eliciting a person's identity around all of those factors, and then tailoring the services or the treatment that we provide based on how those factors are contributing to the person that we see in front of us. So just thinking about, and this is a slide that I will typically use when I'm talking about culture, is that really we want to think about culture as concentric circles, right? And so in this case, we're talking about the woman in the center. But if you think about And this is obviously like I could put an infinite number of boxes on this slide, except that none of us would be able to see what any of them say. So I just like pulled these out, right? But you think about all of the things that go into the recipe that creates each individual woman. Life roles are different, right? So I could have an identical twin and we could be literally genetically identical as far as DNA goes. But in my life role, if I'm a mother and she's not a mother, our experiences are different. In my life role, if I live in the Midwest and she lives in Florida, that impact on our identity is different, right? And so when you start to collect up all of the different facets that actually create a woman, then you recognize that you can't just look and say, oh, you are a woman. You appear to be African American. And so my cultural competency binder tells me that this is what will work for you, right? And so we're going to get a little bit even deeper because I think that is true for all women and really all people that we serve in substance abuse treatment, but especially true for women who identify as African American and who have had the experience of being a Black woman in this country. We have to think about the marginalization that has been experienced, the putting on of identity for us rather than kind of self-determination with us being able to define our own identities, the assumptions that people think they know about us, right? And so as providers, then what we have to be acutely aware of are our own things that we think we know when we see a Black woman or African American woman. And I'm going to take just a second to address those two terms. This is like a perfect example of allowing that woman to give you her identity, right? So I identify as a Black woman because I feel like Black is associated with the civil rights movement and the Black Power movement. And at some point, it became uncomfortable to be called Black. So, kind of like my own individual revolution is that I'm not uncomfortable being called Black. So, I would rather you call me a Black woman than an African American woman. So, if I was coming into treatment with you, I would want you to feel comfortable having that conversation with me. So when we look at the research on what does it mean to be African American, we are falling short, right? When we look at the substance abuse research on African American women, first of all, most of the studies don't tell us if that woman self-identified as African American or if she was identified as African American based on her appearance. Most of the research that we have, especially in alcohol use patterns, kind of compare Black women to Black men or Black women to women who are not Black, but completely underappreciates the I should say, population diversity, right? So Black women of this socioeconomic status compared to Black women of this status, or Black women who are American born compared to Black women who are Caribbean born, or Black women who are in primary caregiver roles versus Black women who are not, right? We know that all of these identity factors are contributing to risk for developing substance use disorder, risk for continuing substance use disorder, possibility for achieving recovery. And yet our literature base is not examining Black women in the way that allows us to kind of draw conclusions based on these nuances. And so that's a little bit of a disclaimer for what we're going to talk about the rest of the time we're here together, which is that much of it is theoretical and based in experience, but not that you will so much find the literature base for it. And if we have researchers in the audience, then I encourage you to take this up as a research basis. So like I said, little attention is really given on reporting on the diversity of use among Black women. Although we definitely know, like, for example, socioeconomically, different socioeconomic groups use different substances at different rates, right? So can we look at that within the population of Black or African American women and see if it can give us any clues for how to tailor our interventions to make them more effective? Um, so after all of that talk about the diversity that exists within the population we're identifying as African American women today, I'm gonna take like the more just homogenous view of African American women going forward and talk about health disparities, right? If we look at the entire group of African American women, um, the health disparities are pervasive and disappointing, really, and cut across all aspects of health. And it's not just health; it's actually other psychosocial aspects also. So legal involvement, educational attainment, housing stability. But when we look at specifically health disparities, then we know, excuse me, as a population, African American women do have disproportionately higher rates of disease and illness, and that is compared to women who are not of Black race. African American women have a wider variety of undetected diseases, and this also stands for substance use disorders. We are experiencing more chronic health conditions, and that's probably related to the first two bullets as well as kind of delayed time to presentation for treatment. We have shorter life expectancies, and overall, we have higher morbidity and mortality. And that's if you just look at general physical health and mental health, but also if you take a specific illness, almost for every illness that exists, if you compare a population of Black women to a population of non-Black women, then you will see higher morbidity, which is negative consequences of health, and higher mortality, which is obviously death. Right. And so we have a lot of work to do to kind of figure out what is contributing to these health disparities and what can we do about that. And so just to drill down a little bit more, kind of to support the statement that I made on the last slide, that almost every organ system that you look in, you can find a disparity. This is not specific to African American women, but this is a health disparity slide specific to African Americans, period. So all genders compared to non-Hispanic whites. And so what you'll see is depression. And I know the text is a little bit small here, so I'll just read it out to you. But African Americans are 20% less likely to receive treatment for depression even once it has been identified, right? So let that sink in. 40% more likely to die from stroke. I'm going clockwise, so I'm at 1 o'clock. 30% more likely to die from heart disease, 40% more likely to be obese, 2.5 times more likely to die during pregnancy or childbirth, 60% more likely to have diabetes, and twice as likely to have a limb amputated as a result of diabetes, 9 times more likely to be diagnosed with HIV, and 8 times more likely to die from HIV. And you'll see why I'm taking my time to walk through each of these, because as we get later in the talk and I start talking about what we need to try to do to make sure we're wrapping our system completely around the woman, we will come back to these physical health disparities. Black women, twice as likely to be diagnosed with cervical cancer. I'm sorry, to die from cervical cancer, not to be diagnosed. Twice as likely to die from cervical cancer, 40% more likely to die from breast cancer, 2.5 times, and this is not just women, this is combined women and men, more likely to die from asthma. So you can see this slide is a combination of morbidity and mortality, but it's really heavily mortality. And so this is just to really drive home the point that we need to be putting our eyes on this. And so you may be thinking, but we're here to talk about substance use disorder. And one of the points that I always like to drive home is that we cannot separate the brain from the body. So the brain is the primary organ in which mental health disorders develop. Substance use disorders are a subset of mental health disorders. The brain is in the body and indelibly connected. So we cannot afford to only look at substance use disorders and discount the rest of the physical, emotional, psychological experience that this woman is coming to us with. But we are here to talk specifically about substance use disorders. So here's a dedicated slide. When we look at disparities in substance use disorder, this is for African American women. Okay, the rate of illicit drug use is a small bit, but statistically significantly higher than the national average. So if you look at a population of Black women, the rate of illicit drug use is going to be about 6.2%, whereas the national average, just kind of general population rate of illicit drug use, is about 5.7%. And I'm sorry, I see that the references didn't get on the bottom of this slide, but that's National Study on Drug Use and Health. If you look at drinking, though, so this is interesting, right? And this is why I talked a little bit earlier about looking at the nuance within the population, because whereas the rate of illicit drug use is higher, the rate of drinking is relatively low. So depending on what study you look at, for African American women, the rate of heavy drinking, and that's defined differently across studies, sometimes more than 5 drinks in one setting, sometimes more than 7 drinks in a week, sometimes just drinking multiple times per day. But if you collect kind of that entire literature up, then the rate of heavy drinking among Black women is between 2 and 8% and decreases with age. So as Black women get older, the rate of heavy drinking decreases. When compared with white women, that 2 to 8% actually becomes 12% of white women are drinking heavily, and we actually see an increase as white women approach middle age. So just like looking at that natural history of alcohol use disorder, both white women compared to Black women, but also the inter-age dynamic between Black women is very interesting. When we look at exposure to trauma, so if we take an entire group of, multi-race, um, and this is not gender specific, but multi-race, multi-gendered group, and look at the exposure to trauma, what we see is that actually whites are more likely to report they've been exposed to trauma, but Blacks are more likely to develop PTSD symptoms when they have been exposed to trauma. And the types of traumas are actually different across races. So we see that there's a signal in Black population that there's actually more kind of exposure to domestic violence and neglect, whereas other types of trauma are more common in white populations. And so we need to use that information, right? Like we definitely think about seeking safety. So PTSD, trauma informed substance abuse treatment module, when we're thinking about gender specific services. But if the traumas are different, then we need to be aware that the type of trauma might be different. And then we also need to ask the question, what is it that maybe explains why Black women are more likely to develop PTSD when exposed to a trauma than other groups? Is it the type of the trauma? Is it the community response to the trauma? Is it because that trauma is layering on other experiences? We need to ask these questions as a population, but we also need to ask this question of the individual woman who is sitting in front of us, because like I'm going to drive home this entire time, every Black woman is a single Black woman. So people of color, we know, are more likely to be stopped, searched, arrested, convicted, and harshly sentenced and saddle along with a lifelong criminal record. That is, in general, that's for every kind of offense and non-offense, but especially for substance related offenses. So Black women are more likely to be referred to DFACS or Child and Family Services as a result of substance use, even if it's comparable to women of other races or ethnicities. And so, and so what we know, so Lisa Cohen, I saw, said, can you tell us the source of the stats on this slide? So all of these stats are mostly coming from SAMHSA Tip 51 or National Study on Drug Use and Health, the most recent data. I did combine some couple of other articles, and I can just give a whole list of references, send it to SATTC so they can send it out to you. I had them in small print in the bottom left-hand corner, but looks like some of them got dropped off. So what we know about the disparities that I just went over for the last several minutes, no problem, Lisa, is that biology alone explains very little about the disparities that we see in health status between Black women and Caucasian women. And so you will almost never see me give any presentation of any sort without some graphic similar to this one that shows the intersection of biological, psychological, and social, cultural, spiritual factors that contribute either to health or to illness. And so, if we believe the biopsychosocial model, we know that biology is contributing. But if biology alone explains very little, then that leaves us to draw the conclusion that psychological aspects and social aspects are playing a huge role in the health disparities we see, both in general health, all those ones I went through, but also in substance use disorders. And so, if we unpack this just a little bit, let's take a look at the psychological aspects of health and the social aspects of health. I'm not going to spend too much time on biology, but I will say that we know the heritability of substance use disorders. So, substance use disorders runs in families. The percentage that we can assign as DNA based risk is 50 to 60%, right? So that means we leave 40 to 50% to be a combination of psychosocial factors. What we know is that psychosocial factors can take a person who has even lower biological risk and still increase their risk for substance use. Or taking the positive view on that lens, if we can put protective psychosocial factors in place, we can augment that biological risk. And so I want to spend the rest of the time kind of talking about some things we can do to try to augment the biological risk that Black women may have for developing substance use disorders. So if we look at the psychosocial aspects of health, from the biopsychosocial model, biological really says you are either born with it, that's your DNA, you inherited it, or you acquire it at some point along the way, right? So we know individuals who get in a car accident, who have the trauma of the car accident and a significant injury, who get prescribed opiates. We just introduced a biological and acquired biological risk factor for opiate use disorder, right? The emotional pain of the trauma as well as the physical pain of the physical injury. So you weren't born with that. It wasn't in your DNA, but it's an acquired biological risk factor. The psychological aspects of health have everything to do with your formative, developmental, and ongoing life experiences, which shape your view of the world. And we're going to spend some time talking about that from a gender aspect and a race aspect as it relates to Black women, because we have literature to show that experiences with racism, both implicit and explicit, absolutely contribute to Black women's risk of developing substance use disorders. And then, of course, the social aspects of health have everything to do with everyday stressors. And so what I've found over my career in substance use disorder treatment is that we spend a lot of time doing relapse prevention and preparing people for those big events that can happen in life, right? So what if you lose your job? How will you manage that without using? What if a loved one dies? How will you manage that without using? What if something exceedingly positive happens? You graduate. How will you manage the celebration without using, right? But what we sometimes underappreciate is that the biggest risk factors for relapse are actually cumulative everyday stress. So housing instability, financial instability, insufficient childcare, relational problems and lack of support, feeling just a little bit underwater every single day, right? The relapse burden of those are cumulative and actually represent a larger risk for relapse than do those big events that we prepare people for. And so I keep kind of giving like the sneak peek into what we're going to talk about later on, but that's a sneak peek into what do we need to be doing to create systems that address those chronic, cumulative, everyday stressors that are threatening the relapse for those of our Black women who have, attained sobriety, or even the development of de novo substance use disorders in those women who have not yet started using. And so if we look at the social disparities that exist, and I alluded to this earlier, as a general population, Black women are at higher risk for living in poverty, are at higher risk for being single mother, head of household, are at higher risk for experiencing housing insecurity, are at higher risk for having primary caregiver status, whether that is of a child or of another loved one, and are at higher risk for having legal involvement, right? And so if we have a substance use disorder program that's not addressing these, then we are not fully addressing those factors that are threatening our Black woman's risk for relapse. And so let's talk about psychological disparities. This is a race-based talk, right? The focus is on African American women. And so you cannot talk about health and Black race without talking about racism. So if you look at the history of this country, racism is a stain on the entire country, but also indelibly on healthcare, a part of which the treatment of substance use disorders are, right? And when we look at racism, we really can look at individual racism. So that's what happens between two individual people. And we can look at structural racism, which is more insidious and built into the systems that we kind of interact with on a day-to-day basis. So educational systems, health systems, financial systems, legal systems, right? There are what could be the remnants of intentional policies that were aimed at marginalizing and suppressing individuals of the Black race, and there can be intentional and unintentional consequences that are still going on these days. We could spend the rest of our lives talking about this, but I want to touch on just a couple of things that I hope will have you leave here today with some tools that you can immediately put to use. And so under the individual umbrella, I want to spend a little bit of time on microaggressions. And then under the structural umbrella, I want to spend some time talking about the lasting impact of slavery and how that rolls into discrimination, and then implicit bias and explicit bias. So starting with implicit bias and explicit bias. When we say the word racism, typically people think of explicit bias. They think of it as an intentional act that is overt, directly expressed. The person who is engaging in racism, but it's really explicit bias, is the one that says, like, I don't like Black people, or I don't think Black people are smart, or you're addicted to drugs because you're Black and Black people are genetically inferior. All of these are, myths that have been perpetuated in actually the medical literature, right? Explicit bias is a conscious bias, so I am aware of it, I believe in it, I ascribe to it, and therefore I let it guide my interactions with people against whom that bias is directed towards. For example, I like whites more than Latinos, okay? The rates of explicit bias in healthcare have steadily been declining over time, which is awesome. And that gives us the sense that we're tackling it, that we're winning the battle against racism. But what we're not fully appreciating is that implicit bias over time actually has not changed. And the literature shows that healthcare providers, substance use providers included, carry the same level of implicit bias as the general population. And so we tend to think, as we get more education and as we become clinicians and as we become administrators, that our biases melt away. But what actually happens is explicit bias may very well melt away, but implicit bias stays under the surface and we become less aware of it, which then puts us at higher risk for acting out on it. And the reason this is important is because we can accidentally act out on implicit bias when we have a Black woman in front of us who needs substance use services. And if we're not aware of our implicit bias, then we create those systems that then rain down structural implicit bias on the very people who are coming to us for help. And so if we look at implicit bias is expressed indirectly, okay? It is called implicit because the person who is meting out the bias is not consciously aware of that bias. It operates subconsciously. And for example, this says sitting further away from a Latino individual than a white individual, or it is the Southwest unassigned seats phenomenon, right? A black person is sitting in the aisle seat at the front and everybody is walking by because unconsciously, implicitly, they are more comfortable sitting next to a person who is not black. And so even though it's unconscious, so bias is a thought, okay? Implicit bias is a thought. So now I'm going into the cognitive triad: thoughts, feelings, behaviors, right? Implicit bias is a thought or a feeling that then unconsciously affects one's behaviors towards another individual. And so if we couple implicit bias and think about how that can be expressed, one example is this concept of the microaggression. And Black women will tell you that we live our lives every single day experiencing microaggressions from well-meaning people. Okay? So a macroaggression is overt aggression with malicious intent. That's not what I'm talking about. A microaggression is a small-scale verbal or physical interaction. The person may not have any malicious intent, but on the other receiving end, it causes pain. Okay? And so I call this the microaggression of the day. I don't see color. It can be difficult for white people to understand why I don't see color is a microaggression. But if I principally define myself as a woman of color, which I do, then if you say to me, I don't see color, what you're actually saying is, I don't see you, or I'm invalidating one of the aspects that you consider to be the most important about your identity. And so when you conceptualize it like that, you wouldn't consciously say to a person, I know being Black woman is an integral part of your identity, but that's not important to me. That would be a macroaggression, right? But the microaggression is, I don't see color. It unintentionally sends the same message. And so if we look at not only those type of microaggressions, but the stereotypes and myths about Black women are not all negative, right? And so you know of this strong Black woman myth, like the myth that Black women have the strongest backs and can make it through anything and will take care of anyone. And trust me, we try. And I mean, we even have this same dynamic kind of going on in the news right now. If you look at the political literature and it says like, we're depending on Black women to save the election or whatever, depending what angle you're coming from. All of that kind of is implicit bias that comes out of this stereotype of the strong Black woman with. But what we see in the medical literature is that this myth actually has significant consequences: delaying treatment, sacrificing self to care for others, negating the need for preventive health care, negating the need for substance abuse treatment, right? And so what we see is that these types of myths and implicit bias contribute to the disparate health outcomes that we see. And then I do want to touch on this concept of cumulative minority burden. And this is the only time you'll hear me use the word minority, because this is another one of my personal revolutions. Because minority carries the meaning that your opinion doesn't matter and can't affect change because majority wins, then you will never hear me refer to ethnic groups as minorities, because I feel like it disempowers and removes relevance, right? But this term is cumulative minority burden. And the idea is that the more minority groups a person is a part of, the higher the burden is that they walk through each day. The higher the microaggression burden, the more they will be subjected to implicit bias, right? And so if you're a woman, that's one level of minority burden. Add Black on top of that, add LGBTQ, add being a member of a religious minority, add being an immigrant, et cetera, et cetera, et cetera. And you can actually envision the weight of that burden on that person. And so when we have that person come to us for treatment, if we don't explicitly address the weight of that burden, then we're not addressing those psychosocial factors that are contributing to substance use outcomes for that person. And so, in the last few minutes that we have, I want to take a look at promising practices for substance use disorder treatment based on kind of that walk that we just went through about health disparities and specifically substance use disorder disparities in Black women. And so, in general, the promising practices for substance use disorder treatment as it relates for Black women is that promising practices all recognize that African American women are at risk for substance abuse, at least in part, and like majorly in part, due to the level of exposure to biopsychosocial and economic stressors, purely as a result of being part of this demographic defined as Black women, right? Promising practices seek to explicitly address those psychological and social stressors and are designed to be individualized, so to appreciate the nuance in the population that's defined as Black women. They're designed to be empowering, and they're designed to be strengths-based. And so promising practices always include social support. And so when we think of kind of like the standard substance abuse treatment program, you have a case manager, right? And we do a psychosocial assessment. But how much do we really focus on ensuring that woman has the social supports and the ability to resolve those psychosocial stressors that are wrapping around her addiction? Okay. And so we know that Black women often experience greater emotional stress. We know they often experience more relationship problems. So are we giving just like one visit with whatever significant other and then documenting we did a couples visit? Are we doing one family meeting and then documenting that we did a family meeting? Like, we need to be sitting with this woman and saying, what are the cumulative everyday stressors based on who you are and what your life is, and how can we empower you and support you in addressing those? So it's a little bit of a different lens than individual therapy, couples therapy, family meeting, treatment plan that's smart, right? Specific, measurable, attainable, realistic, and true. It is actually like I am putting myself in a place to hear your experience, to validate your experience, and to join you as a team member in affecting those variables that are disempowering you. And we have to be so critically aware. Like, I should have added to that cumulative minority burden slide just having a substance use disorder or having a mental health diagnosis, because that comes along with its own stigma that lays on top of the rest of that burden. We so often create this vertical treatment relationship, and that is less effective than a horizontal treatment relationship for any patient, but especially in Black women who have systematically been marginalized and disempowered and put in second, third, or fourth place, right? So the empowerment of validating and hearing and working together, even if it requires going outside the confines of the general program, is going to be extremely important for affecting the outcomes we're getting from these women. Obviously, promising practice are trauma informed, okay? As a general group, Black women have very high rates of trauma and abuse. And I'm going to drive this point home. I'm not talking about only being in a violent relationship or witnessing violence. Those are very important. I am also talking about historical trauma. And I put this picture here to jolt you, because if you have a Black woman sitting in front of you and you're not thinking about the burden of historical trauma, you are missing a big part of the issue. Physical health. I told you I was going to do it, okay? Just a referral to PCP is not enough. We have to make sure these women are getting connected. We have to make sure they're getting connected to their female care, their gynecologic care. We're testing for HIV. They're getting their pap smears. They're having a general health screen for blood pressure and diabetes because the brain floats around in the body, right? And so when physical health is not optimal, the environment that the brain is floating around in is not optimal. And that reduces any person's ability to make the decision to not use when they are faced with that situation. So we have to take a broader view. I know it's like hepatitis C, HIV, referral to PCP. That's kind of like standard care. We have to take a broader view based on that slide that I put up for you earlier. And then if we look at the larger context for promising practices, they have to extend beyond internal deficits. So we try to do that with the recovery-based view of substance use disorders, right? Like it's not a character defect, it's an illness, but there is still a lot of stigma attached to substance use disorders, mental health disorders, and we still put the onus on the individual to make the choice, right? Make the choice, stay away from people, places, and things. Make the choice, know your triggers, have a safety plan. All of that is excruciatingly important, but we have to blow out that view and look at the societal context, right? So how do you deal with a microaggression? How do you re-empower yourself in systems that are inherently disempowering for Black women? How do we involve the community to support those factors, the housing instability, the economic instability, the job instability, the relational instability? It is on us as substance abuse treatment providers to be having those conversations and addressing those factors if we want to make a difference. And I have to touch on spirituality and religion. We have to incorporate this, but we have to be careful about it. This country is a majority Christian country, and we sometimes conflate religion and spirituality, although they are excruciatingly different, right? And if you do a cultural competency seminar on Black people, then it'll say, you know, spirituality is very important to Black people. And as a general sense, that may be true. But again, you have to take that woman in front of you. So the base principle that spirituality and religion share, that sobriety shares, is connection to self and others. Validation, empowering, connection to self and others, a place to turn when you feel like you don't have the internal resources. And so we really need to be looking at the role that that is playing in that Black woman's life who is sitting in front of you and shoring that up. And then finally, an Afrocentric approach, okay? So I put this picture of the Olympics with the Black fist raised. If you have a negative response to that, that's your implicit bias, and it's okay. I want you to be aware of it because that negative response is affecting the way you are interacting with Black women when they come in. We have to get to a point where we can talk about slavery, we can talk about racism, we can talk about current day aggressions, and we can empower Black folks to be proud of the history, the things they've survived, and the capacity for greatness, both now and in the future. So much of that has been systematically eroded, and it contributes to the development of mental health and substance use disorders. And so let's take a poll, and then we're going to roll into questions after just a couple of more slides. The poll is, and nobody can tell who's answering what, so you can just answer with your gut. Substance abuse programs in whatever system you work in whatever capacity, in your system, explicitly address the burden and effects of racism and discrimination as part of the treatment program. Yes or no? Okay. We have some work to do. So if you take nothing else from this program, we're up to almost half of the participants, and nearly everyone is saying no, right? And so what I hope this webinar today will compel you to do is to take this information back to your system and enforce the importance. Thank you for getting the slides back up. Enforce the importance of integrating that into our treatment programs. We have to explicitly address the burden and effects of racism, because that's saying to Black women, I see you, I hear what you're telling me about your experience, I validate it, and I commit to work with you to change it, okay? And so last, offer diverse staff. So it is one thing to talk the talk, and it is another thing to walk the walk, right? Black women need to see Black women on staff, Black women in management, and Black women in leadership. It shows that you have a commitment and a belief in the ability of Black women to be empowered and to make a difference. And when the patients you're taking care of see that, walking the walk, then that will increase the ability to form that therapeutic bond. So this is our last poll, and then we're going to run into questions. The staff demographic in my system, whoops, sorry, that was the old poll question. So we're going to go to the next poll question. Thank you. Substance abuse programs in my system, nope, still the same question. So the question is supposed to be, the diversity of the staff in my program mirrors the diversity of our patient population. So it looks like we might have some trouble getting that poll up. It's okay. You can just go back to the slides because I don't want to take too much time away from the questions. But answer that question for yourself. We can go back to the slides. Answer that question for yourself. And if the answer is no, the demographic of staff management and leadership in my program does not reflect that of the patients we serve. And this is not just for Black women. This is just age, demographic, ethnicity, like the whole bucket. Then I want you to take a look at that, because the people you're serving need to know that you believe in them. And so that should be it. In conclusion, African American women with substance use disorders are a diverse group, but we do share experiences as a result of being Black in this country and the history of this country with slavery and racism. And that results in implicit bias in all of us, microaggression and stereotyping that we have to explicitly deal with as part of culling away those psychosocial factors that are affecting risk for development of substance use disorders and treatment outcomes once they get to us. All of our promising practices are recognizing that there are unique biopsychosocial factors and seeking to address the role of racism in the development and treatment of substance use disorders. So with that, I would like to
Thank you.
open us up to questions and do a quick little promo. The next Women Are Different will be March 7th at 2 o'clock, and we'll focus on Caucasian women. So questions, all righty. I have my box up here. So you can type your questions in the box, and then our tech support is putting them over here in the box for me. So how do you address the lack of cultural competency in your agency of those disproportionately clients? So maybe that means underrepresented clients. And so the first step is the first step for a reason, right? Recognizing we have a problem. And so the first step is really opening the conversation. There are organizational assessments, and you can literally just Google online. There are so many that are great, but organizational assessments for not cultural competency, but for race-based competency in health organizations. And it actually goes through, like, one of the questions is, do you collect outcomes data based on race? Because if the answer is no, you're missing the ball, right? You're missing an opportunity to find a signal that you could intervene in. And so to answer that question, the first step is recognizing we have a problem. And that can be difficult to get a system to admit that. And so you start the conversation, and you collect data about your wait times, your engagement, your dropout rates, your sobriety rates by race, so you can actually quantify the problem that your system has. Staff diversity, okay? How to bring more awareness and to prioritize addressing unconscious biases as a clinician. So if you Google implicit association test, IAT, out of Harvard, there's this project called Project Implicit, which I absolutely love. And it has implicit association tests along any number of spectrums. So it has gender bias, race bias, working mom versus career woman bias, obesity bias, psychiatric illness bias. Like, I mean, there's just a ton of bias tests that they have there. I personally think, just like we have the requirement that abuse has to be some of the CME that we do, and social workers have a requirement, or psychologists have a requirement for psychopharmacology, I really think we need to have implicit bias as a requirement for our continuing education, because it's affecting us every day. And the only way to change acting out on implicit bias is to bring that bias to consciousness so that you can then choose what to do with it as opposed to just acting on it in an unconscious manner. So I would say go on a personal mission to have everybody in your personal and professional life take an IAT, implicit association test. How to make African American women feel comfortable with an all white peer group. So this is tricky, right? What you wish is that the peer group was not all white. So that's the first thing is kind of like to take a look at why that is the case. But the second thing is to get that all white peer group comfortable validating the experience of that Black woman. Because what's uncomfortable about being in an all white space is that pervasive sense, which is expressed explicitly and implicitly, that your experience is not a true experience, or what you're perceiving to be happening is not really what's happening. So it's not so much working with that Black woman to get her comfortable being in a white peer group. It's working with the white peer group being comfortable validating that Black woman's story and experience without feeling attacked. And then also being able to examine themselves like, oh, I did make a mistake. I can own it. I can call it out. I can listen to ways that I can be different. Where do you think the major gaps in gender responsive treatment for substance use disorder still remain? So I think we have a lot of excellent gender responsive evidence-based interventions. But I think the biggest gap, like I spent my time on today, especially for Black women, is the appreciation of the ongoing effects of slavery and racism and being able to address that in an open, honest way without judgment and in a way that actually starts healing. What type of data is needed to increase this knowledge? So we need more data, and there's a little bit of data set like that I alluded to of people of color kind of expressing the impact of micro traumas related to race and the impact on mental health and coping. I think we need to develop that literature, and I think we need that literature to be mainstream as a part of training for clinicians, as a part of training for new employees, as a part of training for everybody who touches any individual in the substance use treatment spectrum. Where do you think the major gaps? I already answered that type of. How do you manage when you are the Black therapist in an agency and notice that there is a lack of understanding of this awareness? It is a burden of professional to be conscious and having to be the teacher to your colleagues who do not see color. So this is a burden that most of us Black women professionals have definitely experienced throughout our life, because then you also run the risk of speaking for the entire Black race, right? Or speaking for all Black women. And then we're up against the stereotypes of the angry Black woman. So you bring up something that you noticed that was clearly race-based, and it's like, oh my God, why are you so mad? And people are sensitive, right? What I say to that is try to approach it with data. So the implicit association test. And then the other thing, I also, every time I talk about implicit bias, I say, listen, we all have it, period. When I give, like I have a full webinar that I give only on implicit bias, and I put my own results of my IAT up there, okay? Because the way the brain works, you are not a racist if you have implicit bias, because people don't want to be racist in general. And so anything that feels like an accusation of racism immediately is met with barriers, right? And so it's like, start with your own experience. Listen, I know I have my own bias, and this lens is coming through my perception. What I want from you right now is just to hear my experience. That's it. And you just start right there, just asking them to hear it. And then I think if you can develop that relationship where you can open the conversation in a non-threatening way, then you have the ability to kind of take it to the next step. Now, what we need from our colleagues who are not of color is to not put all the onus on us for opening that discussion, and to let down those barriers a bit, because it does get exhausting to feel like you have to constantly make sure you're not injuring other people when you feel like you're the one who has been injured. So I think starting with the personal relationships that you have, that you can open that, and then getting allies to open that conversation to the larger group, but always starting with we all have biases, myself included, because it's part of being human. So it's not a judgment. It's just part of being human, and growing up in the culture that we've grown up with. Um, Dr. Harrison, are you seeing any differences between Black women baby boomers versus Black female millennials, and any strategies for working with our younger women? So, this is where the literature is really not supporting us, right? So, I started out kind of talking about how we don't really have that nuance in the literature looking at the different subpopulations of Black women. But yes, I absolutely see a difference between the baby boomers who were raised in a time where you couldn't speak up about race issues because the consequences were too great. And the millennials who are like out loud, like civil rights equality for all, right? And so this is really a wonderful time to be in the space because the children of the future, right? The future generations are always pulling us older folks along to where we need to be in the future. And so if we can follow the lead of the millennials, they're really helping us to develop the voice to even have a presentation like this today. That's all the questions I see in my box. Wait, I see. Thank you. This was such a great presentation. Thank you. How can we stay connected to you and the work you do? So I always feel like a little whatever when I say this, but you honestly can Google me. My website is nzengaharrisonmd.com. There's a contact me. You can get to me directly through that. And then I also have a Facebook page, professional, which is Nzenga Harrison MD, where I'm usually posting whatever I'm getting my hands into at that time. And I
Awesome.
think we are 3 o'clock on the dot.
Awesome. Thank you so much, Dr. Harrison. This was a great presentation. I know myself, I learned so much. And if you all enjoyed this presentation and want to give some feedback, we did put into our chat our survey link so you can let us know how you felt about the presentation, what some things you really liked about it, as well as up on your screen is our upcoming session, Women Are Different, the Caucasian Women. So if you have any additional questions about that session or any more questions for Dr. Harrison, please email us at the email we put into our chat, and that is going to be sattcinfo@msm.edu. We will keep this room open. So if you need any more information or you wanted to jot down that those addresses, it'll be available to you. Again, Dr. Harrison, thank you so very much for coming in and speaking with us. And thank you all for joining us. And you all have a great rest of your week.
Thanks so much. Take care, everyone.